order. It looks like we have a quorum. Just so everybody knows, this webinar will be recorded for a number of reasons so that we get to catch every great thing that you say. And I'm going to ask that the agenda is pulled up now. Thank you. You should have received in your packet an agenda, and we will get started. And I am Andrea Brown. I'm the vice chair. And so again, thank you so much. I'm not sure when we have introductions, are we doing a roll call?
Is Andrea, did you accidentally mute yourself by any chance? Or did we lose Andrea?
No, she's here. We just can't hear anything.
Oh, the joys of technology.
We can see you. We can't hear you, Andrea. Maybe she can't hear us either.
Let me, yeah. Okay, I'm gonna try to call her.
I'll send something in the chat to her. Maybe she'll see it.
Uh-oh. Okay. Andrea, my only suggestion is to sign out and sign back in. All right, I am I'm going to get us moving so that we can move to the presentation today and then get that set up. And then Andrea, I'm going to help you troubleshoot once we get Dr. Chuck up presenting the model. I think where we were when she got cut off was she was going over the agenda. So we have not had a chance to do introductions. We are running about 15 minutes behind. Could people let me know, would you be okay with skipping introductions so that we could move through the agenda? Just use the chat or take yourself off.
Yes.
Yes, I'm seeing thumbs up.
Yes, I'm fine with that.
Great, thank you.
Yes.
Okay, well, so what you see on the screen is our agenda for today. We have planned to have a presentation on the Crisis Now model. As many of you know, the GBRICS partnership was developed to align with this nationally recognized model, and our chair and vice chair thought it would be a good idea to bring Dr. Chuck Browning to join the meeting, moving to the next screen, to give us a presentation on the Crisis Now model so that we can all have a better collective understanding of this model and how it's looking to be applied and what the benefits and strengths are of this. So Dr. Browning will be hearing from him at the presentation, but we'll also have time to engage with him and have a conversation about the Crisis Now model. Then the council will go through looking at the updated or revised vision and guiding principles. And then the BHSB staff have a number of updates for you on the GBRICS committee and work groups. And then finally, we've got announcements. So with that, I'd like to introduce Dr. Charles or Chuck Browning, who is the Chief Medical Officer from RI International, also the Medical Director from Behavioral Health Link. You included in your packet, you had his bio, very impressive bio. One of the key things that he has been doing in his role with both organizations is really looking to apply those principles, trauma-informed principles and infusion of peers into the behavioral health crisis response system in his role. So he'll talk a little bit about that. But at this point, I'd love to turn it over to you, Dr. Browning.
Oh, thanks. Call me Chuck. Can everybody hear me? Okay.
Yes.
It is distressing me to see Andrea trying to talk so hard to get this to work and it not going.
Andre, I'm going to call you in a second to get this working.
Okay. And I was just thinking how cool it was that, or how much I missed the fact that we're not being able to do this together, and doing these talks on Zoom are very different. But I know now if we ever do get together, and I'm going to be there, I'm going to bring my own packet of name tags and just put a bunch of Kristen Emerson's out. So let's get, I'll share my screen if that's okay.
Yes, please do.
Okay. Get my slide up. Can everybody see the screen? Is my
I
screen
can
showing?
see it. Yep.
Okay, great. So guys, thank y'all so much for letting me talk to you. I will try to make this informative and engaging, I hope, and leave lots of room for us to have questions and discussion as well. So if you don't recognize this, this is a Spaceship Earth ride at Epcot. I love going to Disney World. I'm not going to go there in a mask in the hot Orlando sun, but I love this. I love this the place and going to visit it. And for those of you who've never been on this ride before, you basically go through a simulation of a time machine that winds you through the evolution of human communication and how it interacts with the past, the present, and also looking at our future. So in this big giant metal golf ball, you're in a little cart, slow moving cart that goes throughout the whole center and walks you through history and shows you different changes in human communication. And at the end of the ride, you get to, on the touch screen on the back of your seat, you get to design kind of your own future based on a Rolodex of some different choices that you can make. And it kind of looks like this. They take a picture of you while you're on the ride, and they play a short video with your head superimposed on the figure, and kind of walk you through your choices that you made. And Dame Judi Dench is the narrator for the ride. She's awesome. And she basically, there's some kind of cool quote. It's like, while we don't know yet what the future may hold, I think it's an adventure we all share, that she says. And so I hope today to kind of walk you through a journey just like this ride about the history of crisis care, but with a real focus on what some of our choices are for the future. I know that if, so I'd ask all of you to be thinking about that if you were on that ride and you were designing for Maryland, what things you'd want to see in your community in relation to a crisis system. What would be the choices that you would want on your touch screen to touch? For me, one of the biggest things is just having equality and equity for mental health and behavioral health and substance use disorder to be equitable and similar to what we do for medical emergencies and the medical emergency system that we have. So that's a big one. I think it would be a care system that has all kinds of layers of continuum of care so that people really get the level of care that they need for that particular crisis, and that it's not just you either go to the hospital and wait for a bed or you don't get care. And that there's lots of layers of things in between for what you need. I think it would be a care system that really works on opening up access to all, just like we have for an emergency room or a 911 or EMS, that it doesn't matter who you are, where you are, or what's going on, that you get access to care. And then that care is based on standardized and evidence-based practices that you can only get when you have a true system that's collecting data and using quality improvement principles to look at what works and what doesn't work. And doing that across the whole country in a way that we've done in emergency services to be able to track things that help improve emergency medical situations. I think it would have a care system that really works on de-escalating the crisis and being very trauma-informed, so that we have things that are warm and welcoming and comforting to help de-escalate a crisis, that we give people more choice instead of moving them through a process, that we offer connections to family and supports in the community rather than, and trying to help maximize and support those connections in the moment of crisis rather than isolate the person, put them through really traumatic situations, which is what often happens in our country. And then finally, that our crisis system works so that we actually use people with specialty in treatment of behavioral health and support in what we do, and that we only involve law enforcement when they're needed for public safety. And then when they are needed for public safety, that there's great coordination and collaboration between the two, just like you'd see if EMS went out on a call where there was public safety concerns for a medical problem. So I think of putting all those things together for my future template, and I hope you'll be thinking about what you'd like to see. In terms of those criteria, the cool thing is that it actually is not that far away from being able to realize. There's a premise called Crisis Now that you guys are going to have me talk about, and it's based on the statement of 3 core services that matter, plus a technology and a crisis care principle framework that surrounds all 3 of those, that when you put it in place, creates an infrastructure that can create an integrated system that's equivalent to what we have for medical services. So you have kind of 3 big pillars of this. One is someone to call, so the equivalent of a 911 or a crisis call center hub. Someone to come to you when you need someone to come to you, that would be the equivalent of paramedics or EMS. And then finally, someplace to go. So a specific crisis receiving center that's designed and specializes in decreasing and de-escalating the crisis, keeping people safe there and working with them on that. And then finally, having the technology that can help coordinate and help keep these things integrated and collaborative and working the correct way with different valve management tools and things that I'll get into. When I talked about the parameters for a care principle in SAMHSA's National Guidelines for Behavioral Health Crisis Care Toolkit, which is based off of the principles of Crisis Now, this is some key things, is that in any of these 3 layers, what you're looking for is that, 1, you're going to address recovery needs. So it's not just about what your diagnosis is or what's wrong, but also what are your strengths? How can we collaborate? Part of recovery focus is being collaborative and giving people partnership, truly person-centered, not just saying it, but actually letting them have choice and work on what works for them in their recovery. Looking at the whole person. So being able to address whole health needs, as well as people's connection with their families and their supports and what that plays in their life, social determinants and how those things factor into crisis. One of the principles is a significant use of peers. I've been doing this work for over a decade now, and thankfully we have a really strong peer presence and peers advocating and guiding and co-designing the things that we do in our care principles. And that's a huge part in any of these 3 pillars, I think, to be successful in engagement and connection with the people that you're serving. And then finally, trauma-informed care, so that we're being able to truly meet people where they are in that situation, creating a comforting environment, one that is inclusive and has awareness of all kinds of diversity, so that we can support and work towards doing that in a better way. Suicide or zero suicide safer care systems in place that includes things like direct treatment of suicide, screening and assessment tools, safety planning and connections of follow-up that are based on best practices in zero suicide or safer suicide care. It's really important to have safety and security for your staff in these 3 parameters of Crisis Now. And so those are part of the essential care principles and how you do that. And then finally, coordination with law enforcement and emergency services, because there is and always will be an overlap in some cases with that. So I'm Chuck Browning. Thank y'all so much for letting me come and talk to you today. I'm Chief Medical Officer at RI International and also Medical Director of Behavioral Health Link in Georgia. And so RI International is known for kind of 3 big things. The first is they were, back in the 90s, they started out in the Phoenix, Arizona area with a real focus on supporting and driving for peer employment training and the use of peers. And our model of peer employment training has been, the backbone of what established the VA system and in UK. And we still consult internationally on peer employment training and peer support focus. Then secondly, in the early 2000s, the original leadership group of RI International started focusing on involving peer support, peer staff actually working in crisis in the Arizona area. And it became a really popular thing when it was shown how it worked. We had coined the term the living room model, which was designing a combination of the physical environment of creating a place that looked more like a living room and a home with a warm, welcome environment, along with these recovery principles and the use of peer staff to show that there's really a lot more things than just starting a medication, for example, to help people de-escalate their crisis. And now we're the largest nonprofit provider of crisis receiving centers across the country. We also are fortunate enough to have partner with a group out in Southern Australia, doing a center out there, and we consult internationally and in dozens of other states on how to do crisis care systems as well. And then I've just recently started as the medical director. It's a part-time role for Behavioral Health Link with Georgia, who's now in Ohio as well, that provides for the state of Georgia, covers the entire Georgia crisis and access line. So that first pillar of Crisis Now is the crisis call lines. They do that for the entire state. And then they also provide half of the state's mobile support team coverage. Georgia is one of the few states that has complete coverage of the entire state by mobile crisis. So I'll be able to hopefully share some experiences about how those things work through both of these roles that I am fortunate enough to be involved in a really exciting time now. But before I get to the future and talk about now, I do want to go a little bit backwards to think about where our crisis system has been and where it is now. So I'll start that by just talking a little bit about this picture. So this guy's having chest pain, and then there's also the picture of a motor vehicle accident. In our country right now, if you have chest pain, it doesn't matter what your demographics are, your age, gender, whether you have any money or not, whether you have a home or not, whether you're rural or urban area, you are going to be able to call 911. You're going to be able to have ambulance come out to pick you up if you needed it, and you're going to be able to get access of care in an emergency department. There's also going to be a variety of different options for you based on what your need is for the chest pain. Not everybody goes to the cardiac ICU. Some people go to a cardiac step-down unit. Some people just stay in the emergency room, and when they realize they're not having an actual heart attack, are given or do some blood work to make sure they're not having one, and are observed for a short period of time. And when it's thought that they're safe based on evidence-based practices, they're connected to follow-up to then go and follow up with a cardiac outpatient need. And then there's all kinds of layers of support in between there. Cardiac rehab units and wellness centers and all types of levels of care based on what your needs are. Unfortunately, that's not the case in behavioral health. And so I'll give you an example of a story, a couple of stories to help paint the picture of what it's like now. It was probably about 3 or 4 years ago, a friend who I'm going to call Scott, his wife went to high school with my wife and me, and it was a Sunday afternoon, and we got a call from her, and she was in tears, very upset, and had just gotten a call from her husband, Scott, who, although he had had depression before, off and on, and you would have never known it from just interacting socially with him and things like that, was having a sudden onset of severe suicidal ideation, thoughts of harming himself with actual intent and ideas of how he would do it in his head. And it was very disturbing to him, and he was reaching out for help, and he was upset and tearful. His daughters are home with him. But yet they didn't call 911. They called me because they knew I was in that field to ask for advice. He was afraid of being locked up and taken away from his family. He was afraid of potentially police coming out in the neighborhood to come up to his house to interact, because if they call 911, that's what they expected would happen. And so they were asking for advice. And thankfully, in this situation, I had another friend, a colleague, who was able to work him in and see him that day. We were able to do some safety planning on the phone to make sure that there was no access to weapons available. He was very fortunate that we figured out that a big part of it was a medication side effect that had just started with a new medication change recently, and that was able to be treated that day to give him some immediate relief, and it really helped de-escalate that problem. And he worked a lot with some safety planning and was able to stay at home, get the support he needed, get connected to outpatient follow-up without encountering all those things. But it's all over the United States. Those scenarios don't always happen. And you end up with all kinds of layers of different things that occur. I've been an assertive community treatment team physician in a rural area in North Carolina for many years. And some of the things I've seen happen to folks that I work with who have a diagnosis of schizophrenia, who are wonderful folks, but if they end up in a crisis and end up in the emergency department of a small ED that has no mental health support, some of the things that in ways that their crisis has been managed when they've been challenged on a tough day with severe symptoms of psychosis would it just brings tears to your eyes, knowing some of the things that I've seen happen to them just through not knowing how to respond and how to help those folks. And then a lot of times they get, at least in the state of North Carolina where I live, people get shipped all over the state, hours and hours away from their ag team and from their family in order to get care. And so there's a lot of things that are broken in our system of that. And if you looked at where our system is now, we're probably at what our emergency department services would have been for medical problems back in the 50s or 60s when it's all said and done. And so we've got a long way to go to make those changes. But the beauty of it is that we really are seeing a movement forward with that. So now, in all across the country, as I said, people either take their loved one or they go themselves to the emergency room, or they call 911, which is going to bring a police car out. And so if you can think about being someone who has had past trauma with law enforcement, or, has had an experience with being picked up by police before with an involuntary commitment, and these folks show up, even if they're unbelievably well-trained officers in how to manage these situations and are kind and caring and have empathy, there's just an automatic trigger that comes when that happens, and that we use law enforcement, in a huge way across the country as our primary intervention when people need to come out to someone in the community. And what that leaves is a lot of times, because of the challenges, people either end up going to jail or going to the emergency department and waiting for a period of time because of needing a bed. So the answer to this dilemma, and something that's been developing for quite some time, is this Crisis Now 3 core services with care principles and technology to support it. It does not mean that there aren't other parts of the crisis continuum that are out there, because there are, and they can all be very important. But when these 3 services are working together and integrated with the right kind of support systems, it's not only a better support for people in their community, but it's also actually extremely helpful in kind of healthcare cost savings and cost savings to communities. And fortunately, we have multiple states where we're seeing these pieces work really well, that give evidence of how to do it, the things that work, and the actual benefits of putting that in. So I'm going to share that some. Now, I'll say this, across our country, we don't really have any state thus far that would probably be the ideal gold standard of all 3 services working together. And I'll give you an example. In Arizona, they have a large regional crisis call centers that are taking care of that job. They do have mobile support across the state that do a fantastic job of going out and seeing people in the community. And they have unbelievably successful crisis receiving centers throughout the state. However, law enforcement in Arizona still is the majority intervention out in public. Even though there are some mobile support teams working, it's still more the rule that law enforcement is going to be the first encounter that and bring people to crisis receiving centers. But in the state of Arizona, people do not go to emergency departments. In Georgia, they have a really strong crisis call center and really strong mobile teams in the communities throughout the whole state. However, the crisis receiving centers that are available through different parts of Georgia are very variable. They oftentimes have lots of rules about medical clearance and things like that prevent people from necessarily getting easy access to care. And so a lot of people have to funnel through the emergency room, which creates, again, people waiting in emergency rooms for days and difficulties in increasing healthcare costs and things like that. So I'd like to walk you through some details of each of these 3 services, talk a little bit about that, and then go into some deeper data. But I'd like to pause for just a second to see if there's any comments, ideas, thoughts, questions before I kind of delve into each individual layer. Or do you want me to just keep going?
I think you can keep going. So far, I don't see any questions in the chat.
Okay, great. So the first service, go backwards here, would be our call line. And so this is the equivalent to 911. What's really cool about this is that we are moving towards having this now as a national service with 988. As I'm sure you all are aware, by 2022, it's going to be an expectation that we have this new system that is the equivalent for behavioral health care. And it's not just meant to be a suicide prevention line. It's to handle all behavioral health crisis concerns, substance use, and all of those things. And that is being done in several states, Georgia and Arizona specifically, but multiple other states are working towards accomplishing this and moving in that direction now. When you have this system working well, it not only helps connect people to care, but it really does a good job of de-escalating and getting people that only need a connection and some immediate support, and then connected to follow up through the crisis call without ever having to have someone go out to them or them have to come to a crisis center. So we're looking at anywhere between usually close as 90% of issues are being able to be resolved on the phone. through a combination of different support techniques, again, doing zero suicide safety principles and those types of things. And that's been working well in some of these states where they have these centers present. So as we look to the next steps in the future, as your state is setting this up, one of the things that's so important about that is when states start looking at doing mobile teams all over the entire state, rural areas and states that have frontier areas, it becomes a real concern about how do you get all that coverage. But when you're handling 90% of the interventions by the call, you can see how important that is. The second piece is mobile teams. So again, this is the equivalent of paramedic or EMS going out in the community when someone needs a little bit more of someone to come to them. It doesn't mean just going to an emergency department and seeing people who come there. It's really getting out under bridges and at people's homes, and it's showing up in a plain clothes in a normal car, so that it doesn't bring a lot of attention to you when if you're in a neighborhood. And oftentimes it's a two-person team, which is important for safety reasons. The Crisis Now and National Toolkit really supports the use of peer staff in this team for engagement and connection. And oftentimes we talk about using real-time GPS technology to help create like this smarter system of how to get people to different folks. And there's different quality indicators and measures of how to do that well. Oftentimes, again, this is a whole nother set of folks that if there was only 10 to 20% of folks that got through that needed a higher level of care to mobile teams usually de-escalate anywhere between 70, 85% of calls in these different states where they're functioning, so that there's even a smaller percentage now people who need a higher level of care than that. And they oftentimes, mobile teams are not just helping in the moment, but also are participating in follow-up in the next day or two in that next step of connection as part of the role that they serve in the community. Why are these two services so important when we talk about what's been happening in our country with law enforcement's engagement, the effects on healthcare disparities, the effects on how many folks with mental health who oftentimes are people of color that are interacting with law enforcement and horrible outcomes. We talk about the sequential intercept model. With the onset of 988 and properly functioning crisis lines, as well as mobile support, you stay in intercept zero. From the majority of everyone in the community you're serving, you never have to get local law enforcement involved. In Arizona, numbers, we think as high as anywhere between 97 and 99% of mobile support calls do not need police involvement along with them. And there's very rare times that you have to get police coordinated either as a standby or to clear the scene in terms of weapons or things of that nature. But so many other incidents that we see happen to this day in the news can be completely intercepted by having these lines functioning and working well in the community. And then the final piece in the three pillars is this crisis receiving facility. And one of the key components of Crisis Now, a lot of states have some form of crisis receiving centers. Sometimes they're built into a hospital along with an emergency department. Sometimes they're a freestanding unit. But there's a lot of variety and a lack of standardization. And the Crisis Now principle is really focused on that 23-hour observation and treatment site. It has to function like an emergency department in terms of access, meaning no wrong door. You are open and finding ways to serve the community and have people have access to care. And when these are working correctly, you do not have to say no. So many communities, law enforcement is still involved, and it creates an easy way to have law enforcement connect people, be in and out in less than 5 minutes, and then the person receiving specialized care and behavioral health supports for their crisis. In these centers, they're also, designed, and the way you do that is by having the tools in place to be able to manage folks that have really high acuity, folks that have comorbid medical problems, and have an infrastructure to assess and manage that as you go forward, as well as being able to manage substance use, because over half of the calls are going to involve a combination of mental health and substance use things that you see. Now on this graph, you're going to see all these other levels of service. These are other things that continue to help. So I talked about 90% for crisis call lines, then 70 to 85% with mobile teams. Well, in Arizona, our 23-hour temporary observation treatment units, and also in other states, we usually resolve about 60 to 70% of those cases are able to go back and return to the community. So again, we've again handling more and more people at the appropriate level of the care fit to need that they have without having to connect back and just wait in an emergency room to go to an inpatient unit for maybe a week until Medicaid's not covering their service anymore, and then discharge them back home. So there are other levels of care, though. As you can see, there's these short-term crisis beds that can have shorter time periods for people having an average of a stay of like 2, 3, 4 days. There's respite and residential services, oftentimes can be completely peer run, urgent care and lobby services. There's all these other things that if you have those 3 core systems working correctly, make a big dent in being able to help support the majority of the crises that come. And then what the result of that is that you have massive healthcare savings. People are getting connected and getting back to their community much sooner. And you make a big difference in people not waiting in emergency departments or going to jail. And finally, the tool pulling this together is technology and the use, just like you would in air traffic control, where you're tracking a plane and making sure that while it's in the air, you know where it is, where it's going until it's safely to its destination. And that's kind of the mantra of the technology that's being used. So VHL has multiple products, and there are different things that make a difference in terms of where people are in the referral pathway. There's Connect, which is like an electronic outpatient scheduling system that the call center and the mobile teams can actually schedule outpatient appointments in the middle of the night, because the community outpatient resources are required by the state to give open appointments for follow-up in this system, so that they're automatically getting connected to follow-up appointments that match like a demographic and a location and things of that nature. Whereas BedTrack is that for an inpatient. So it's keeping the community's electronic, it's an electronic inventory of crisis beds in the community and where there's openings and those kinds of things. Care2Go is a GPS tool for mobile teams that helps with dispatch based on location, when people have finished their call, that kind of thing. Metrics is a dashboard to work on quality improvement measures. So like on a call service, it might be, looking at the number of calls that are going over 15 minutes in that moment, or it might be monitoring of how well a call team is doing overall on de-escalating crisis, things of that nature that you want to measure and manage and have quality improvement focus on. And then voice is a really cool thing that they've been in conjunction and working on development with a group of researchers out of Japan that actually measures emotional distress in the voice. So not what people are saying, but the actual emotional distress, and looking at real-time interventions, what that does to decrease emotion. And they're in the middle of doing studies and looking at things like that. So it's all kind of cool futuristic things that are out there being developed to help support these systems. So I'm going to give you some more data about how it's been working in different states and kind of impact it's having on communities, if you don't mind. So this is Maricopa County, over 4 million people, where Phoenix is. And you can see we've got these 3 large crisis receiving centers spread out over this population. And it's been now since, the early 2000s, as the community looked at, there's this group called Access, which you'd think, oh, that's great, it's going to give care and access to everyone, but it was really, the abbreviation stood for cost containment. And they were in charge of funding for many different aspects of the community's costs related to crisis care. And they decided that they were going to, this was pioneered by a group called Connections that has a site in Phoenix area as well as in Tucson. And they pioneered this principle called No Wrong Door, which basically says, partnering with CIT and police, that police can come and be in and out and drop people off in less than 5 minutes. And we're not going to say no. We'll take care of assessing medical needs. We'll take care of assessing high acuity. It doesn't matter. Whatever's going on, we'll take care of it. And you go back out in the community and help support folks. And what they did was they drastically changed the use of emergency departments. And it basically, if you were going to run a crisis receiving center in that area, you were not able to say, no, I'm not taking this person. They're too intoxicated or they're too aggressive. And so it became a principle that showed that over time, when you're doing this, the amount of impact and what it's done in Phoenix is amazing. So I'm going to give you some figures. In 2017, the amount of folks that were served by these crisis receiving centers saved 37 full FTEs of law enforcement that was able to do public safety instead of being involved in the mental health system timing wise, based on the work that was diverted away from them having to do it. 45 years of emergency department boarding time. And let's think of some number, $270 million in cost savings, which was over double the cost of the crisis care services that were offered. And then that allowed them to have money to actually help support and flesh out more outpatient and preventative resources and things of that nature. So again, really huge impact in the community by having these things function in that way of no wrong door by changing the dynamic. And RI, like a lot of crisis receiving centers around the country, in the early mid 2000s, we were still a niche boutique center. We were very recovery focused. We accepted about 50% of law enforcement drop-offs back in 2014, but we did not accept everyone. We still were to some level cherry picking, and that became something that you're going to get shut down if you don't change that in that area to match that. And what you find out though is if you are creating barriers of access to care, even if you're not doing it on purpose, there's implicit bias things that are going to happen that are going to affect seeing someone as more aggressive or seeing someone as having, not as stable and not being able to serve them. And then you end up not creating an equal open access of crisis care to everyone. So if you look at our numbers back in 2014, before we started this no wrong door movement, we were at about 57% and look at the numbers we were serving. Fast forward that to 2020, where we've served now over 25,000 straight law enforcement drop-offs, some voluntary and some involuntary, coming in from the community, and serving over 2,000 more people that are coming in with law enforcement than we were back in 2014. That's 2,000 more people that did not go to jail and did not go to emergency department. And the majority of them actually were able to go home either from our short-term 23-hour observation unit or from a short-term hospitalization service that's right connected to the same center called our living room. So major impacts. When you pair that kind of thinking, and again, going back to that sequential intercept model, when we establish 988, there's going to be a huge opportunity to make an even further push nationally towards helping law enforcement not have to be the primary responder to mental health in the community. These are some of the calls that we have now with Lifeline, Suicide Prevention Line, and local and county state crisis lines. But we estimate that, and this is a conservative estimate, of 24 million of the 240, 250 million annual cost to 911 are mental health, behavioral health related. So when 988 gets activated, the possibility of being able to divert a total of about 40 million calls directly to crisis call lines that are going to be able to intervene on 90% of those, and then mobile support. Think about the numbers of people in the community that are not going to be connecting with law enforcement and what kind of impact that can have. This is another data point that was really fascinating, interesting, especially in the climate of what we've been working on and trying to accomplish in our country in a time of racial reckoning that's ongoing. And that is a group asked us, a panel asked us who was studying racial disparities in healthcare, asked us to look at our population of folks that we serve, people of color, and in this case it was specifically percentage of Black or African Americans in our population. And if you look at our average for the whole company in these 5 states where we did the numbers, the general population, 12%. Populations coming into our crisis services, 27%. So over double the penetration. So there's much more to study and understand about what that means. But one thing it does mean is that when you're doing no wrong door and you're opening up access of care to everyone, that's showing that there's a huge percentage of people who are being intervened that maybe in the past might be going to jail, might be taken to a hospital and taken away from their community, or just maybe not finding access to care in general, that are now getting connected to a particular service. And there's, in the future, when we talk about touching these things on the touch screen, I think in the future, where we have data and metrics to ensure access for all demographics, so that we can really look at not just access to care, but also starting to look at, what kinds of crisis interventions work for different populations and make a difference in de-escalating their crisis. Can we measure, is our staff got the kind of diversity and the training and the support to be inclusive to someone that's maybe different than them that comes in, and what's the experience that they're having when they come in a crisis, in terms of a trauma-informed care type of principles and those things. And that's something that we're just starting to scratch the surface on how to study it and look at it. But you have to have these infrastructure things in place to be able to really take a look at that and work on it like it needs to be done. So finally, close with some kind of cool kind of future things to think about. This is not just Star Trek, but they actually do these kind of control centers in NASA. And there's been so much of this revolves around valve management and using the efficiencies of technology to look at where people are and what's happening with it. And there's actually a group out in Australia and Gold Coast that do this remarkably well for their medical health. And this is what it looks like. And it's like a hive. It's like NASA, Star Trek Command Center, and they're managing beds and quality metrics and things that are happening in the moment with supports. They are working towards developing this for behavioral health now in Gold Coast, taking the same model and applying it to crisis principles that they have come and toured and worked with us on that. So it's just kind of cool things to think about, that you can have this hive kind of networking and working on what people are doing and what's going on with them. And then finally, as I mentioned, Crisis Now really focuses on these three core principles, but it does not mean that these campus of connection and these other layers of crisis continuum are not important, because they surely are. Just as if, like I talked about with medical problems, we have all kinds of different levels of care for folks. The same thing is true, that it's necessary to have different things. So this is in the UK. It's called Life Room. It's a peer-run service based upon a lot of the work that we did when we were consulting with UK years ago. And it's mostly peer-run respite and residential type services, as well as a drop-in center where people can work on many other things besides their illness. They can come and work on connections, relationship building, employment support, peer employment training, housing needs, social determinant things. And I think we'll see a move if we have the structure to create a path to intercept someone when they're in their crisis, so that they can either get back on their recovery path or connect to their recovery path. It really helps to have these complementary type of campus of connection things available. So I appreciate you guys letting me kind of walk you through different pieces. I hope this made sense, but I'm really looking forward to being able to have a discussion with you and answer questions, talk about concerns, ideas, things like that, because we're in a moment of time with 988, and then the unprecedented support and funding to make a move to do something different in the way that we coordinate and interact with law enforcement and our whole crisis system of how to reboot it. It's a really, really exciting time to be focusing on what can be done in the future and the things and impacts that we can have. So thank y'all so much for letting me share this talk, and I'll turn it over for questions.
So thank you so much, Dr. Browning. We certainly appreciate you. There may be another voice that you'll hear after mine. There were a couple of questions. One specifically was, how did you integrate the lifelines and the various hotlines across the state and into that air traffic model?
So specifically, if you're talking about the history of how that happened in Georgia, there was a time period before they created Georgia Crisis and Access Line where there, and I'm not an expert historian on this, but there was a time where there were multiple smaller crisis call line groups, and then that was merged into one statewide. And then there's other states that have just 2 or 3 large regional ones. The reason that I forecast that with 988 coming, that we're going to see emerging to larger companies providing it in, or not larger companies, but larger call lines, doing a bigger spectrum of care, is because it's going to require that to have the infrastructure for staffing and the technology needs that those crisis call lines need to function effectively. So there were changes, and I don't even remember the exact year of kind of when that transition took place in Georgia or in Arizona, but that was a process of kind of creating a much larger section.
Thank you. I hope that was, I know that Dr. Jones is on, and I know she has a follow-up question she will ask. The other question came about regarding 911, and somebody the person that asked the question said she may have missed it, and we know that it's complicated, but how does the call hub work with calls to 911.
So in the future, how is that going to work?
Yes.
I mean, that's part of the, Andrea, that's part of the work is there's a national call. It's just gained a huge amount of momentum with stakeholders from all areas of involvement in crisis systems in states and nationally, and SAMHSA and NASHBID and on this call. And that's one of the many things that has to be worked out. Remember that slide I showed you with the potential 40 million calls and the change of that happening? The impact of how many and how are we going to coordinate? It's not like all of a sudden people are going to immediately call 988. There's still going to be a lot of people when this thing gets activated that are going to call 911. And so one of the big next steps is to figure out what's going to be the coordination, the collaboration between 911 and 988. How does that work with technology? How do we connect and do that? And I think it's also going to be it's going to probably need to be a public education. Logic is going to have to come out with a new song specifically for 988 instead of the 1-800 number. But it will a focus on being able to help educate people so they know to call that. But if it's done correctly and it leads to the kind of principles that we talked about, you can see how it has a much better chance of being a feed forward scenario. And if you have peers involved in the 988 calls, along with supervision with licensed clinical support, and you have the right training in place, people are going to hopefully get a warm voice and a supportive, crisis de-escalation type experience when they make those calls. And then that's going to hopefully, again, from a branding perspective, you're going to want that message to get out that's what you want to do when you're in that situation. But I think that's going to be one of the bigger challenges is that coordination, because it's not like there's going to be a switch flip and everybody's going to stop calling 911 when that happens. Another case to think about is if you own a convenience store and a gentleman is or anyone is in your convenience store challenged with some symptoms of intoxication or mental health symptoms that is causing a ruckus inside your convenience store. How are you going to educate people in the community to call 988 instead of calling police when something like that happens? And that's going to be a challenge. Or is the system going to be more when they call 911 that there's going to be a system in place to help sense, is this a real safety issue or can I send mobile support instead? So it's where are you going to have that intercept to look at that? But you can totally see how that's going to be something that in communities that will be needed to work on.
And it's going to be a game changer. So I am going to do a soft handoff to the chair, Nikki, because there are some other questions. And so again, thank you so much.
Thank you.
Hi, thanks. Can you hear me okay?
Yes, Nikki, I sure can.
Okay. I'm having computer problems. I can't seem to get the camera and the phone to work together. Chuck, in your experience, what how have these past efforts in other states been funded?
Oh boy, so this is what I call Paul Gaddis, who's worked for Magellan and Medicaid and knows this stuff backwards and forwards. But in terms of funding, there's, for example, 911 is funded so the actual crisis call lines right now, it's funded by a small fee on cell phone bills. And my understanding that's probably how 988 is going to be funded. Okay. Specifically to raise money to be able to support the services that do that. In terms of the other funding, mobile support, crisis receiving centers, and other levels of care that are built in there, it's different. It's so different for different states based on the amount of Medicaid penetration and those types of things. However, when the funding potential is, like I said, is unprecedented right now for the ability to have funding to be able to help start working on this infrastructure and establishing it. And again, there's multiple states, and one of the reasons this is so popular is not only does it offer a chance for better overall care, but it also saves money. It costs a lot of money for people staying in the emergency room for 4 and 5 days, or it costs a lot of money for a lot of people going to inpatient services that don't need a 7 to 10 day hospitalization. So there's all kinds of ways that when you have this in place, creates cost savings to be able to help support it. But there are ways, if probably in terms of getting into super nitty gritty about billing codes and how to set that up in the state, that's not my level of expertise, but at RI and our consulting, definitely with Paul, and we also use Tom Betlack, who's the former Medicaid director of Arizona, oftentimes helps speak and work with states on helping explore how they did it, how they set it up, how it worked. I hope that was enough of an answer.
Yeah, so it was helpful. I don't think that we expected you to get into the billing codes for us, just a high level perspective. Unfortunately, I cannot see the chat from my computer. So are there questions?
I see a hand raised by.
Yeah, we got a hand raised from Dr. Hepburn, and I see Katie Rouse also asked a question in the chat. So let me do, I don't know who was first, so I'm just gonna do Brian first and then Katie.
Hi, Chuck. Nice to
Hey,
see
Brian.
you. You look good.
Oh, I'm in a hotel room sitting in front of this cool graphic that David designed.
Well, hopefully you brought some warm weather to Maryland. Yeah, so Chuck, maybe you could say something about the changes that had to be made in Arizona regarding transportation, because one of the problems some states have is that the police are restricted where they can transport people, especially if they're involuntary. So I know that you talked about the police drop-offs being 50% going into your crisis program, and I know a certain number of those are involuntary. So what would have to happen in order for the police to have the authority to do that?
In order to have the authority to take them to crisis receiving centers instead of an emergency department?
Yeah. Because some states, the police are restricted. They can only take the individuals who are involuntary. They can only take them to the emergency room on an emergency petition. And if they're voluntary, they're also restricted as to where they can take the individual. So that seems to be a necessary step in order. I was just wondering if that was already law in Arizona, or if you had to change that.
No, I don't think it's law as much as that the actual crisis receiving centers get licensed to be involuntary commitment centers, and you go through a licensing process with the state. That's all of our sites across the country. That's the process. You actually have the Joint Commission safety things, you get licensed and have the capacity to be designated as an IVC receiving facility. So then it's totally okay for the officers to bring people and present the paperwork, and you have all of that network and infrastructure in doing that. That's a great question. The other piece, and this is another thing that happens as you're designing your system, is EMTALA laws can cause a lot, in a lot of other places, sometimes actually fire or EMS is transporting people to crisis receiving centers separately. And some people have to do special pilot programs that get approved by counties or states in order for them to drop off at the crisis receiving center instead of an emergency department because of concerns of EMTALA violations, but it is being done successfully at multiple places across the country. So those are little nuances to think about when that's happening. But if you want your crisis receiving centers to truly be no wrong door and be able to manage that, you have to have the ability for them to be licensed as involuntary commitment receiving centers based. And that's another really, it's a barrier, but it's something that you have to address as you're designing your crisis system, is what are your involuntary commitment laws? Every state is a little different in the way that works. And I'll give you an example in how that difference can affect just even some of your care practices. So in Arizona, their involuntary commitment law, when someone comes in, you have to make a decision within 72 hours. And there are only certain special hospitals that if someone needs past those 3 days is going to need a higher level of care, that they have to be transported to that facility. Versus in North Carolina, some of our short-term inpatient units that have an average length of stay of 3.5 days, we can support those people up to a week related to those calls. And when that happens, we're able to partner and collaborate and work with the person on involuntary commitment about, we'd love for you to be able to go home from here. And what's the one thing that we could work on together that would help you feel safer, for example. And so they don't have that luxury in Arizona, except for the first few days to make a decision and see if they feel like that's going to be safe or not. And so they lose the ability to partnership just because of the way the involuntary commitment laws are set up.
Okay, thank you.
And then one other cool wrinkle, like, so California, they have, we have some actually unlocked voluntary urgent mental health care centers that are not truly no wrong door, but they are part of their involuntary commitment laws allow that if someone is being petitioned, if they say, I will go to that mental health urgent care and let them evaluate me voluntarily to the police, they are required to take them there for that under 24-hour observation period voluntarily to be, so they actually have a more stake in the game in terms of not wanting to be on a voluntary commitment to work with that group and partner with that. And then decisions are made about that. And it's just an interesting wrinkle that's unique, but I do see sometimes a partnership that gets spurred on by having that ability to have the more partnership related to involuntary commitment laws.
Okay. Thank you.
Katie Rouse, did you want to get your question in?
Sure. Just, I mean, it's in the chat, but I just want to say thank you so much for highlighting the importance of having prior trauma or fear of involuntary commitment, and just what a huge barrier that creates to people using crisis services when they need them, but also crisis services being appropriately delivered, right? With because the bias or discrimination that can happen with folks who are kind of don't understand behavioral health challenges, just all over leads to situations escalating in a way that could have been avoided and sometimes becomes lethal. I just really appreciate that the model understands that having options and having choices is fundamental and foundational to any effective crisis response system. I'm wondering, in the communities, where this model has been introduced, have you experienced any opposition from folks who kind of have take a more coercive approach to crisis? And just, can you talk about maybe how those conversations went, if they happened at all?
I have done a lot of those talks. I have this whole sequence of talks called I've named it the fusion model, and I describe it as almost like an analogy would be a Reese's cup, where you have characteristics of chocolate and characteristics of peanut butter that are awesome. When you blend them together, you get like this super synergistic experience from it. And I find that happens sometimes in terms of there's some really great things about the biomedical hospital model of care. And there's some really great things about the pure recovery movement. And sometimes they clash more than they need to, versus taking on the chocolate and the peanut butter, put them together and getting the best of both worlds. And so part of what we talk about with that fusion model is how to pull those things together. So to get into the nitty gritty of what you're describing, when we talk about in our training and what we do at RI, really focusing on, there's this comfort versus control. And so when you're in a crisis setting, there's always a balance of safety and safety concerns and risk management versus control, and what that does to autonomy and partnership and collaboration. And so I think a huge part of that is the training, the type of people you hire, the way you support an environment of a culture of doing that is key. It's like the difference in, again, I showed that picture of Disney World. I do a whole another talk about how to do exceptional customer service in crisis care or in healthcare. Why can't you have that? But there's a lot of places that don't have that level of care, of exceptional customer service in other business arenas comparatively. And so it takes a system to be able to do that. But moving forward, it would also be really nice to have data points and ways to measure and manage, as I mentioned in that future hope, that we can look at, what tools really make a difference in decreasing crisis for a particular demographic group that maybe we don't even know or have a clue about that yet. But what I do know is that peer support creates that connection and engagement to help take down some of those boundaries. If I have a peer service person at our staff who tells the person when they first come in, hey, it's gonna be really cool talking with Dr. B. I promise you can trust him. He's, to do this. It changes the whole dynamic from the get-go, 90% of the time in that kind of work together. So I'm rambling a little bit, but it's kind of a culture thing and puts those things together, Katie, to make that come together.
And then Nikki, I see we have a hand raised. Pastor Hatchett, did you have a question?
Yes, I did. Thank you so much, Adrian. I appreciate that. Thank you again, Dr. Browning, for the wonderful presentation. I do have a question.
Yes, sir.
Corey, you muted yourself.
I lost you for a second. You got muted.
Okay, thank you. I'm sorry.
There we go.
You gave a perfect illustration about the convenience store. You know, someone coming into maybe the convenience store, there's an issue, so we call the crisis call center to deal with that. Do you have any information based on your past experiences? What is the time turnover for someone from a crisis mobile to come and to address that particular issue? Oftentimes when people are calling, they want something immediate. And they want it quickly. And so is there proper staffing for people to respond to them calls in a quick manner? And then secondly, and then what happens in the instance when someone is resistant? So if they do show up in time, what do you do when someone is walking away? There's an issue. How has that been addressed? So I'll go from that.
Great two-part question, Corey. So the kind of things, to talk about the first one, I think, one of the measuring quality points that you have to measure. So when I talked about the software of the GPS location tools, as well as that dashboard tool, so one of the quality indices that you're measuring is the response time on mobile teams. And so you staff. First of all, you got to have the right efficiency patterns to make sure that it's running in an efficient way. But then you have to have the right kind of staffing and overlap to cover those kinds of calls and to make sure that you're accessing it. And that can be different in a urban area versus a rural area. And that's one of the things as this crisis now is evolving over as a national model, is helping to figure out what are those standards going to be. What are the tools going to be to help maximize that timing? Because like you said, when that is needed, you need to know that somebody's coming out. Now the second piece of your question is, again, going back to this comfort versus control. If they're, and again, in Arizona, they estimate 97, 99% of calls do not need law enforcement. But if there was somebody that was really aggressive and even before the call got there, a lot of times they'll have law enforcement on standby. Oh, they're available. They're not showing up in the sight of the person to decrease triggers and things of that nature. So the goal is to have that safety net there if something were to happen where someone just was not able to be de-escalated through collaboration and working with them and coordinating with them. The reality is, if you have that in present, the majority of all your cases are going to go well if you're using those practices and treating people as human beings with dignity and working with them and connecting with them. That is your biggest safety thing, period. But when you don't have that, you do have to have the safety tools and infrastructure in place to be able for those smaller numbers of cases to help support that as safely as you can. So you're still going to always have some layer of probably law enforcement involved, but you want to make it as small of a percentage as possible. In our crisis receiving centers, there's a similar dynamic. In Arizona, again, there might be someone that comes in really intoxicated with methamphetamine that is not in touch with reality in the moment, very paranoid and aggressive, and just might be out in communities randomly punching people, jumping and throwing their head into a car, things like that. And they show up at our crisis center, and we have to say yes, and we'll take them and manage that. And so you can sometimes do the best practices in terms of medication support, being really calm and giving them food, because food is a big key with methamphetamine intoxication to help people relax and kind of calm down, and food, sleep in a dark, quiet room. But even sometimes even with all those things, sometimes still somebody is acutely not safe to other people and starts trying to punch another staff member or guest there. And that's where you have to have the infrastructure in place to do safety holds and things. And we try to minimize that if at all possible. We always look at it as a treatment failure and review every case that happens in that way to look at, because if you don't, you'll end up doing it more than you should. But you have to have it there for safety of the staff and of the people that you serve, the ability to do it in those rare cases where that happens. And I think that's going to be a really important principle that we're going to have to develop with this overlap. Same principles will overlap with law enforcement and crisis continuum. And I would say they probably have that a lot better because they're used to doing it with emergency medical services with EMS and law enforcement. But it's going to be an interesting mix as this moves forward, how to best show what programs work the best to help manage that.
Thank you.
And I see we have a hand raised from Dr. Jones.
Hello. So thank you for your presentation. I noticed that, and you mentioned this, that the implementation of the Crisis Now model looks a little bit different in different places. I'm wondering, with the varied implementation styles across the country, have you learned anything new or different, or have you all adapted your model in any particular way to take into account anything that you've learned by the various ways that this model has rolled out? Or have you always stayed true to, this is the model and this is the aspirational goal that everyone should be reaching for?
No, we fail fast. Dr. Jones, we fail fast. So you always have to be ready to, not let perfect be the enemy of good, and just move forward and figure out and be when you're doing innovative things, you always have to react and readjust to things that you learn. So I think there's a lot of flexibility in things that we learn from every state that we consult with, and look at what their needs are. One thing that's consistent, though, is these Crisis Now principles make sense, but a lot of folks in different states, they get what Crisis Now is, but they, but they want to layer it on top of what they already have sometimes, and not change some of these core principles that you have to really have the system work well. And so that'll be a challenge to you guys as you're looking at this moving forward, is how to, what are going to be the biggest barriers or resistances to really having those core things working the way that they're supposed to work. Because if you don't have where you can serve anyone, anytime, anywhere, and then if you don't have some underlying principle of using those essential crisis care principles, there's more likelihood that it's going to have challenges in different ways.
Thank you.
And just to give a few more details, Dr. Jones, there's other things that really affect the differences. Every state has different involuntary commitment laws, different Medicaid structures, different licensing services for like crisis receiving centers. Different states have different abilities of how they bill, like peer support and different things like that. So there are so many layers to the onion. And so there's always new things that you have to pop up and problem solve and work through as you're going through that journey.
Chuck, this is Nikki again.
Oh,
can you
go ahead, Nikki?
And thanks. I really appreciate that last made about the fact that, as we move forward with this, we are going to have to think about the things we currently do and do them differently. So if we're just trying to layer the Crisis Now model on top of the, on top of our current infrastructure, that will be a challenge. But if we try and integrate it into what works well, what doesn't, sounds like we have a much greater opportunity for success. I have a question for you related to sort of our long-term planning is, we had made the decision to not include the crisis centers as part of, of our model that we were putting forward, because the funding opportunity was limited. Those bricks and mortar facilities are the most expensive component of it. And then also, we needed to first build up additional community-based infrastructure before turning towards those bricks and mortar facilities. But with your sort of, you said that the crisis centers are a critical component of the model. What advice would you give to us as we move forward? What advice would you give to us about thinking about when to implement the crisis centers, how to implement them? Of course, knowing that that's not part of the grant that we have right now, but that's something that we'd potentially be looking to in the future.
So what a question. And again, this is not, I would not say this is my expertise in this lane, but what I would say, I think, would be that you got to look at the data. It's easy to see states that have used that model and what it did to the impact of the cost of the services, as well as the cost savings of the services. And so I think taking the time to look at the data, if you don't do that, what do you expect will happen? If you, and if you don't have that resource in the community, when people need that higher level care, where are they going to go? And what is that cost going to be to the community versus the cost of providing those crisis services, and what that would do to the overall system? So I I think if you have, I mean, and that data's there. I mean, there's a Crisis Now has a bed calculator that has an unbelievable amount of sophistication that you can do different pieces into the equation. Again, that's a little over not my specialty in what I do, but when we consult, we go into states and help look at that. So at least you have the information as a group deciding on the pros and cons of what those choices are going to do to the system. I hope that answered the question enough about that, but that's what I would think.
It definitely does. I mean, it's something that we will, you know, as we launch this 5-year journey together, I think that's something that we will always have an eye on in the future is you know, when and where do we move forward with those crisis centers. So thank you.
Well, when it's all said and done, if you think about my presentation, if you don't have a no wrong door emergency place for people to go when they need that level of care, they're going to go somewhere. They're either going to go to jail because if they cause enough problem in the community, law enforcement is going to find, you know, there's probably always some kind of misdemeanor that can be charged to take the person to jail if they don't want to go wait with the person at the emergency department. Or if they all go to the emergency department, if without the right kind of specialty supports and things, sometimes that stereotypically that doesn't seem to work out that well in helping have that 60 or 70% of crisis resolved in that first 23 hours and a good connection to follow up and those kinds of things. So there's going to be likely costs by not having that in from the get-go, and it's important to look at the data so you can kind of guesstimate what that potentially could be when you're making those decisions. That's what I would say.
Thank you. Adrienne, are there any more questions?
I see one more hand raised, and also just note 6:20. So maybe this is our last question. Linda Rains, I see your hand raised. Do you have a question? Oh, maybe that was an accident.
There we go. Sorry about that. There we go. Just having trouble unmuting myself. Hate to end with a nerdy question, but I would love to hear, Chuck, your experience with IT challenges and what you've learned over the years in implementation, whether it's software integrations or training of the users who are essential to success or uptake of users and properly using the really expansive systems you've created here to share information and collect good data.
It's not a nerdy question. It's a really important question, Linda. Again, there's so much technology that offers the ability to help support the process efficiently and to help minimize errors. That's one of the things that technology offers so much is to help people not slip through the cracks, to have warnings and prompts. So it's always an ongoing quality improvement process. Is how can we find measures that matter that we need to be following? How can we make sure we're building those measures into our electronic medical record? If it's at our receiving center, what processes are we using as systems to look at that? Switching over to an electronic incident reporting system so you can really look at trends on different things that happen at centers for safety perspective, safety surveys, and using technology for staffing about are they feeling safe at work and giving feedback about what's working, what's not. Obviously all those technology things I shared with you on from BHL can have a big impact on the fluidity and how well things work. But if your folks don't know how to use them, so a big part of your new employment orientation, as well as because you're constantly innovating and looking at new things, you have to have ongoing training as well to boost how are you supposed to use these tools and things like that. And we're unloading a whole new set of tools at RI this year, looking at some new measurements on suicide risk and connection and engagement of our staff in the moment, not just at the end of a longer stay with a patient guest satisfaction survey, but actually doing measurement of engagement tools in the moment, and actually measuring tools of recovery that we're calling recovery vitals, like you would do for vital signs or fever, temperature, those kinds of things. But a person's like 3 simple questions done by our peer staff, but all the team sees the scores to look at the overall picture of what are we doing to de-escalate crisis and trying to have that piloted in as a way to really measure recovery focused things that we're targeting. So it's always evolving, and you always have to have training to kind of match that. But it's a challenge. You got to have people that can help support the development of those and how to have it working. And I would say the more that your systems can talk and have exchange of information in the crisis continuum and stakeholders is a huge key too in being able to measure the community's data and what's happening with the quality of care in the whole crisis system.
Chuck, this has just been amazing. Very, very helpful and so informative and exciting. It makes me very excited,
Thanks, Nikki.
you know, for the planning we have ahead of us. So thank you so much for your time and your expertise. You've been so generous.
Oh, thank you. There was one other question I saw about children, and I can just real quickly say, you know, having effective crisis call lines and mobile support, typically your goal then is to have some cross training so that those two groups can specifically be able to help manage the support, because that's the majority of the referrals are going to fall in those two. There is the beginnings of crisis receiving centers and specialty care for adolescents and child and a new development in that, but it is definitely not as far advanced as it needs to be moving forward and looking at that. But I think there's some certain principles of that, and that's what I talked about. There's all kinds of populations being able to manage intellectually developmental disorders within the community that enter into the crisis system, folks with dementia and cognitive impairments that end up acting out because of confusion or delirium, and how to help support that within the system. But again, if you start saying at your crisis receiving centers, if you start saying no, instead of just being an emergency part that triages people that come in and then gets them to the right place, is the goal. But when you do children and adolescents, you have to have special services available, separate physical space so that they're separated from adults. And you can't even do it all for all ages of children. You have to separate out younger children from adolescents. So it's got some more complicated wrinkles to it, but it is a process that's moving forward.
Thanks. Any last thoughts or questions for Chuck? Okay, great. Thanks again.
Thank y'all. And I'd like to thank Kristen for letting me pick at her by everybody's name being her. So thanks, Kristen. So Adrian, am I supposed to sign off now, or I didn't know what the...
Yeah, you can.
It is? Okay.
You're welcome to stay for the rest of the meeting, but I know you just landed and get settled. But thank you so much.
Thank you all so much. Please pass out my email if you've got other questions, or if we need to get connected to someone that has expertise in some of the other lanes for more details or deeper dives, to let me know and then get you connected to different groups. Thanks, everyone.
Thank you. Bye.
Thank you.
Bye.
So, Adrian, I know that on the agenda we had Andrea leading the next discussion, but I think she had to leave for another meeting. And I believe the next thing on the agenda is to revisit the vision statement and principles, guiding principles.
Yes. I am pulling those up on the screen now. Hopefully everybody can see the revised GBRICS partnership vision and guiding principles on the screen. Can somebody let me know?
Yep, I can see them.
Great.
And yes. I apologize to the group that my camera is not working. So I apologize that you can't see me. It was either hear me or see me, and I guess hearing's probably more important. So my apologies. So as a reminder, we had all provided input on the vision and the guiding principles last GBRICS meeting, and there were some recommended changes, and we wanted to let BHSB incorporate some of those changes and revisit this hopefully with the goal of taking a vote on the vision and the guiding principles. Also want to remind the group, as we discussed last time, that there was about 3 months of input with community and stakeholder groups to try and get input on the vision and the guiding principles. So while we are refreshing this for purposes of where we are today, this is something that has been discussed in the past, had community input, and also recognize that this is something we will revisit and change as GBRICS evolves. So while this may be the vision and the guiding principles today, it may be appropriate, however we decide on these, it may be appropriate to revisit these in 6 months and a year and change as this project evolves. So with that, I'd like to open up discussion and see with this group whether or not this adequately reflects the discussion we had. And one thing to call out is that there was a letter sent from Disability Rights Maryland asking that we incorporate equity into the vision and the principles, which is reflected here today. But Disability Rights Maryland had said that there hadn't been appropriate community input. And so I just wanted, for purposes of transparency, let this group know that I received this letter. But Adrian, I think it might be helpful, if possible, I don't know if you have this information handy, but can you mention some of the groups that we had reached out to include some of the community groups, some of the consumer groups that we had reached out to for input in the past? I think that might be helpful for this group to hear that. I don't know if you have that information handy.
Yeah, I can summarize some of the process steps that we've used as well. So like Nikki said, the vision and guiding principles were developed prior to submitting the proposal to the HSCRC for the GBRICS partnership. And we did, as she noted, we had a 3-month process where at what are regular GBRICS monthly forum meetings, where we reviewed these principles, this vision and principles, and really wordsmithed and made lots of changes. So that was one time, and that, like Nikki said, that was with the monthly forum group. That was a group of variety of different partners, including behavioral health providers, such as our crisis providers that are across the 4 jurisdictions. It included people with lived experience, our hospital partners, other community groups, foundations such as the Horizon Foundation and the Trill Foundation. So that's one way we've gotten input. We also had a full day symposium when we were developing the GBRICS project back in March of last year, where we also reviewed the vision and guiding principles, and again, asked that group if these were on the right track. And that full day symposium included many of the same partners that come to our monthly forum meetings, but probably just more of them, I would say. And then we've done a variety of individual briefings with a variety of different groups. Any group from the Baltimore City CPIC, which is the Collaborative Planning and Implementation Committee. That's the group that supports oversight and implementation of the Baltimore City Consent Decree, to local behavioral health councils, to other local groups that many of our hospital partners and other people have connected us with. And then we've also taken input that we've gotten from letters and other communications. So we've gotten input in a variety of ways to try to tweak these from a variety of different community partners over the course of the past year and a half. Does that help to answer? Does that summarize, Nikki? I can certainly go into more detail if you want to.
I think that helps. Does anybody have any questions for Adrian about past efforts to get input regarding the vision and guiding principles? And again, my apologies if I can't see the chat.
Okay. This is Katie from Honor of Maryland, and don't have scripted comments, so I'm just going to go off the cuff. I think it's first, thank you. Like, it's very obvious from the way that the proposal is written, from the meetings thus far, from all of the meetings that you've held over months and months, that community engagement is a living activity, right? It's not a checkbox to be like, we did it, we consulted the community, but it is an ongoing, sustaining thing. I had the ability to be part of this meeting that Disability Rights Maryland put together, kind of specifically right as the GBRICS has been launched, asking for voices from the community. And I just want to say that I realize that for many people who are involved with this proposal, this is not the first step, right? This is like the 14th step probably in this process. But for some of us, this is the first step, right? The GBRICS has launched. We're now at the very beginning, and starting off on a good foot, right? Like really doing the thing that we said that we were going to do is important. I guess my question is, what does a vote on this today make possible or not possible in terms of moving forward, because it seems like there is more input that wants to come in, that we want to come in, and the community engagement committee's work is, I mean, it's one of the standing committees. So do we have to vote on this right now? Can we continue to seek input in just a continuous improvement way? Or what does this open the door on? I guess process-wise is my question, if that made sense.
Yeah, Katie, I think that's a great question. I think one of the benefits of voting on things today, on voting on the vision statement today, is it will allow us to start, moving to the action stage. However, I do think, you raise a valuable point about getting the appropriate community input. I think what would be helpful to know is, so we have the community committee that will be one of the standing committees as a forum to provide input. But one of the things that I do worry about is that I think this GBRICS has been very transparent, and there have been forums to provide input in the past. So we would just need, if there are groups that didn't step forward in the past to provide comment, we need to ensure that that input will be, if we were to extend this, that input would be provided in the near future, because we don't want to just keep pushing this off and wordsmithing. So I guess the question is, do we have the right principles here? And if we do, then taking a vote on the vision and the principles today will allow us to really start moving to the action phase. If we don't have those, then let's continue to discuss that. I'd love to hear from others in the group.
Well, Nikki, along those lines, my memory is not fresh, but I do remember that we did just spend a little bit of time discussing this at our last meeting, and I'm curious. There was some input in terms of suggested changes, and could somebody share what was done with that input and where changes have been made in the document compared to what we received in the first meeting?
Linda, I'm happy to do that if you would like.
Yeah, I was curious about what changed, because we did discuss this last time.
So some of the feedback that we've received from the council, but then also from other partners between the last month and now, is that we specifically have a principle on equity. So the first bullet on the screen is that added principle that was not there before. So we added a principle. We felt that it needed to be called out specifically, listed at the top, in fact. So that is a new principle. The other two pieces of feedback we got were to tweak the language around minimizing police involvement, to acknowledge that there are times where there are still times where we're going to need these specialty teams and co-responder model. So that language, which is the fourth bullet, has been tweaked. Basically what's been done to the fourth bullet is there's been language that's been added. I think previously it just said minimize police involvement, and we added that extra kind of extra second part of the sentence there.
Great.
And then the last change is the sixth bullet down, support collaborative processes to substantively involve communities and stakeholders. Before it just said stakeholders, and we specifically added the language communities there, because we wanted to call out communities and make sure that that was just specifically and explicitly noted in addition to stakeholders. So those are the three changes from last month to this month.
Thank you. That was very helpful.
Thoughts from others on the vision and the guiding principles?
I'm just going to say one more thing. This is Katie again. I wonder if we can also conceptualize this as these are some principles that this group assents to. Yes, we're going to start here, but just with a very keen awareness that we don't know what we don't know. We don't know what new insights are going to be brought forward that are really important. So rather than thinking about this as a vote on an approval of something, which brings in some power dynamics I think we're trying to dismantle when it comes to community engagement and doing that in an authentic and effective way, and more looking at this as an opportunity for everybody sitting on this council to say, yes, I definitely buy into this. And as new priorities come forward, I can then give a choice to buy into those as well. I just want to really voice that community engagement obviously is really important. Some of the this is what it looks like, and those are my comments. Thank you.
Yeah, Katie, I think that's a great point. You know, these guiding principles I think we'll find ourselves revisiting them, and particularly once the community committee is up and running and has had the opportunity to provide input.
And
does anybody else have any?
Yeah, this is Ryan. I just want to say, and Katie, I appreciate your comments related to different components of where people have been across the evolution. From somebody who's been at this from the beginning as one of those eyes and voices, the evolution of what you currently see on the page is much, much stronger than where we started. And I think that that's a good thing, but I also think that that shows that it has been, from the very beginning, a living document over the time, and we should definitely view it as that moving forward into the future.
And I think that what you have here are very sound guiding principles. I mean, this is a 5-year initiative, which will likely go possibly, you know, for the foreseeable future. And usually, you know, when you're looking at vision and guiding principles, you're not going to set it for what it's going to be for the whole 5 years. It's going to be, this is where we are today. And then as the time goes by, we might add some principles. I can't imagine anything on here that will be removed, but there might be some other things that get added over time because we don't know what we don't know. So, but I do think that these principles are quite sound and kind of hold on, I'm sorry, and help. Mommy, this won't work. Okay, I'm sorry. I gotta go. Hold on a second.
Yeah, no, I was just gonna say, Dr. Jones, I think it's a great comment about the removal too. I think that provides a lot of value as we look at this.
Yeah, and I think that provides some additional clarity as sort of why there's some need to move forward with a set of vision and guiding principles today, is that as we start to put out other documents around GBRICS, as BHSB develops any RFPs that need to go out, we'll need to incorporate the vision and guiding principles in that work. And so I think that is why I think there is some sense of having a timeline on this, but I also, as everybody has stated, I think everyone is open and willing to additional input and continuing to mold these and let them change over time.
And I think what I was trying to say is that these principles seem to be very well grounded.
Thank you. Any other thoughts? I'd love to hear from the group. Are we comfortable with sort of formalizing this, the guiding principles? Are we comfortable formalizing them today, recognizing that they will likely change in the future? Change for the better, of course.
Nikki, it's Maria. I'm comfortable with them. I mean, to Dr. Jones's point, I think they're very well grounded, and they paint a picture of, you know, what the vision is for the work of the group. And to the extent that there are major changes or modifications that need to be made, good to know that we can revisit that later.
Nikki,
Thank you, Maria.
Would you be requesting a formal motion to approve at the moment? I'm seeing a lot of yeses in the chats as well.
Yes. Yep.
Okay.
Yep.
All right. I'll make the also move to approve the vision and the guiding principles as reviewed in the last 2 meetings of the GBRICS Council.
There a second?
Second.
Anyone opposed? I don't hear any opposition. And I see a lot of supports in the chat. Adrian, are we good?
Yes, thank you.
Okay, great, thank you. And please, Katie, thank you so much for your input. And please know that I think that everybody's in agreement that this is a evolving vision and principles.
I think it says a tremendous amount that we can kind of verbalize the fact that this is an evolving document, and saying yes now doesn't mean yes, no more changes forever. It means yes, this looks good and we look forward to continuing to update it. So thank you for that.
That is a great way to put it. Thank you. Okay. Adrian, are you going to walk us through the Community Engagement Committee?
Yeah, I can actually frame up the next part of the discussion for today. So BHSB has updates for the council on where we are with getting the Community Engagement Committee and then 2 other work groups established. If you remember at the last council meeting, we presented to you a purpose for the Community Engagement Committee. We have since taken that and fleshed out certain areas of work, some of which we've already been talking about in the vision guiding principles discussion, but this committee was intentionally created as a permanent, standing committee of the GBRICS Council, because we know that we need to do a lot more to be partnering with the communities throughout the implementation of the GBRICS project. And I'll just say right off the bat, I think we also acknowledge, and we acknowledge this in the development proposal, is there's not a lot of community trust for a variety of different types of stakeholders, including government, including hospitals, including nonprofits and service providers. And we know that exists in the community, which makes it all the more important that we need to have community engagement being at the forefront of this work and informing it as we move forward. So we've done some work to flesh it out, and I'd actually like to turn it over to Dan Rabbit, our policy director, who will be leading this committee for BHSB and helping to support its work, to walk you through this.
Sure, thanks Adrian, and good to be with you all. Like Adrian said, this is a key component to the GBRICS partnership, and like Katie said, this is an ongoing, regularly attended to aspect of our work together. So in doing that, we're setting up this committee. The goals of the committee will be to craft the general overall strategy and recommendations for how to accomplish community engagement, to focus on all 4 jurisdictions of the region, to make sure all stakeholders and community members across that very varied region of the state have opportunities to get engaged, to identify the forums and methods by which to get communications out, and to be able to obtain feedback back from the communities on how the implementation is going, and how service design and communications about the project should be designed, and make sure that they serve the communities that we're intending. I think the way I've been thinking about it is the committee can help the GBRICS leadership and coordinating bodies get information out to the community, but also can help get information from the community back to the folks who are making decisions about GBRICS. So on the next slide, we have a list of like all of the different types of community members that we hope to recruit for the committee. We've been doing lots of outreach already to, we've talked to a lot of folks who are represented here on the council, and been reaching out to a variety of contacts. You can see here, we really hope to both have geographic diversity, but also diversity in terms of the type of communities that members of the committee represent. For the purposes of time, we were going to maybe see if folks have ideas. If anybody has ideas about organizations or individuals that they really think we should consider to have as part of the committee, maybe you can put them in the chat. That might be a good way to get it, and that way we can get like the right names and contact information if you have it. And I think another just key thing to point out is this is an open committee, and will also be something that we're going to figure out iteratively. So if we come up with a good start, a good roster for the committee, but then we realize there's a gap or there's a certain community or perspective that's missing, we can always add more people. And the committee really, will serve as nodes out to the broader community. So we can also come to other community groups, even if they're not directly represented on the committee. So that's kind of it in a nutshell. And I'm really looking forward to getting this off the ground soon, the next couple of weeks. And really appreciate any support y'all can give to helping us get this together.
Thanks, Dan. And then, so like Dan said, we, since we're running short on time, if you have suggestions for members for this committee, please don't hesitate to drop that into the chat, or you can email Dan or me directly. The next two work groups we wanted to make sure that you are aware of is the Comprehensive Call Center and Mobile Crisis Team work groups. And so for these, I'd like to turn it over to Shauna Brutt, who is our GBRICS Implementation Director.
Everyone, as we heard in the Crisis Now model presentation, the two of the key components of the work that we're going to be doing is the comprehensive call center and the mobile crisis team expansion. So the comprehensive call center work group is really going to be looking at the nuts and bolts of the call center. So in order to have a call center, we need to have the regional expectations and standards for the dispatch of mobile crisis services. We need to, as we heard, there's amazing data collection abilities through the software. So we need to think about what we want to collect, what kind of outcomes we want to look at, make sure we have that solid technical support. And then of course, we need to figure out how this is going to integrate with 911, 211, and 988 when that comes on board. And then the mobile crisis team work is really going to lay that groundwork so that we can expand mobile crisis team services and really make sure that the needs of all specific population groups are going to be met. So we need to have both a regional standards in order to do that, but to also make sure that we're meeting specific population groups. And then in addition to that, we need to make sure that the mobile crisis teams are able to integrate with our call center, including how we dispatch and how the GPS tracking will work. So there will be a little bit of overlap of the groups, but they do have their separate kind of scope of work. And again, like Dan says, these are open groups. We do want to be very inclusive with who is participating. Of course, we will have representation from our current hotline providers and mobile crisis teams, as well as the LBHAs, but we also need to really have people with lived experience and subject matter experts and all these other groups involved as well. So again, you can put ideas into the chat, or you can email me with your recruitment ideas, and Dan and I are going to coordinate, so hopefully we won't overburden, have you serving on many, many different committees, but you are of course welcome to participate as much as you desire.
So Nikki and council members, those are the updates we have on getting these groups established. I know we're almost at time, but are there any quick questions for the team or anything you think we should be considering as we move forward?
Adrian, no questions for me, but I'd love to hear from others.
I also don't see any in the chat. I am not hearing or seeing any. I will just say that this will not be the last time you'll be getting updates on the work of these work groups and the committee. So we will certainly have more opportunities to discuss this. And like Dan and Shauna both said, these are open groups. As we dive into the work more, if we realize we need the voice or representation of other partners, we will be looking to bring them in.
Thank you, Adrian. Thanks for that update. Any updates from any other council members? Any information to share?
Yep, I have a couple of updates. If you like, it's Ben Lawner.
Great, thanks, Ben.
Hey, I'll be very brief. We had a discussion today with the police and representatives in the mayor's office, and this relates to the involvement of 911 in behavioral health triage. So there is a significant barrier obviously encountered in trying to get all the data systems to kind of talk to one another. So we're going to talk to Fire Communications, and we've also engaged a couple of city data analysts to figure out how we can, number one, get the data points and then abstract them from all the different databases. So this quality assurance and oversight of the protocol is going to roll out obviously concurrently, but we just want to ensure that certainly everybody is safe, and we can always report out to the stakeholders when there is a mistriage. So the goal is always to get the appropriate resource to the patient at the appropriate time, and those discussions are ongoing. They've been moved to a standardized kind of standing meeting involving representatives from police, the mayor's office, and Fire Communications. That meeting actually just took place at 2 o'clock today, and we have another one next week, so happy to continue reporting progress.
Ben, thanks for sharing. Any questions for Ben? Any other updates from any other council members?
This is Brian. I just had real quickly 2 things. Is it okay to go ahead?
Yes, please.
So the first is MACPAC, the Medicaid and CHIP Payment and Access Commission. They had a presentation this week by Erin McMullen, who actually used to be with the health department in Maryland. And it was focused on behavioral health, specifically on crisis services. And the recommendations there were very much in line with the work that this group is doing. In addition, there was a report that came out from the National Association of Medicaid Directors, a paper on behavioral health. And there was one of the focus areas was on crisis services. And again, very consistent with the work that this group is doing. Why is that important? Because as someone asked earlier of Chuck about payment and financing, the fact that Medicaid may be more involved across the country and that there may be increased attention to innovative ways that Medicaid may be used, it could really be helpful to augment some of those areas that you want to add to the GBRICS. I think part of the discussion earlier today was on the stabilization unit. Well, if you have a way to pay for the stabilization unit, it may be a good thing to add. And Medicaid, innovative Medicaid payments may be a good way to do that. So thank you.
Yeah, Brian, thanks. Those are great updates. It's always good to hear that we're heading in the right direction, right?
Yep.
Any other updates from the council members? Anything else to share?
Can I ask a quick question? It's Maria. Do we know that there isn't some Medicaid waiver opportunity to cover, at least initially for a period of time, to cover these services? I'd be surprised.
Yeah, there is.
Okay.
There is actually, and I'll send something that just came. Kirsten Baronio put out something recently, and I'll send that around. It basically talks about using the 1115 waiver and other innovative ideas with waivers that may be able to pay for some of the services. So I'll send it to Adrian.
Thank you.
And I can send that out to the council then too.
Any other updates or questions? Okay, our next council meeting.
And I'll just note one thing that was in the briefing memo is that the HSCRC is meeting this Wednesday, and we will be presenting the GBRICS partnership to the commission. So just wanted the council to be aware of that.
Thanks, Adrian. Okay, great. Our next council meeting is May 10th, same time. Look forward to seeing you all again. And as always, thank you for your participation and apologies for the technology issues. This is the new norm though. They seem to be, this isn't the only place I've had technology issues. But, thank you, everyone. Thank you for your time and participation. It was a really great discussion today.
Thank you.
Thanks.
Yeah. Good night.
Thank you.
Bye-bye.
Thank you.